Hello, ladies and gentlemen, and thank you for waiting. Welcome to the Maryland, Virginia Nursing Home Improvement Network webinar. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Erica Morrison. Erica, the floor is yours.
Thank you, Erin. And on behalf of VHQC, welcome to today's webinar, Dementia Care Teams and Interdisciplinary Teams to better understand resident behaviors. As mentioned, I am Erica Morrison, the Learning and Action Network Manager at VHQC. I am joined by our Nursing Home Improvement Consultants, Harold Hansen and Linda Harris. And again, we welcome you to today's call. Before we get started, I just have a few items to share. Today's session will be recorded. You will be emailed instructions on how to access the recording from our NHIN online community. There will also be a question and answer period at the end of the presentation, but also feel free to send a question through chat. Click on the chat icon in the right upper hand corner of your webinar screen to view and to use chat. And speaking of chat, we have a little question in there for you. We would love to know where you are from today. So if you've dialed into the webinar, if you can drop into there what city in Maryland or Virginia that you're representing. It'd be great to hear from you. So just to move on a little bit, I would finally like to hear some feedback from you this afternoon as we do future planning. So please take a minute or two to answer the evaluation questions that will appear on the right-hand side of your screen at the end of the hour. So with that, I will move on and introduce our speaker today. We are very pleased to have Sonia Barsmith back with us today. Many of you attended Sonia's presentation back in June on reducing antipsychotic medications through person-centered care and had the opportunity to engage with her during an office hours call in July. Sonia is a consultant and the principal of Sonia Barsmith Consulting, LLC. As a consultant, she works with organizations to operationalize person-centered values through education, evaluation, and practice. She serves as a consultant on our Maryland, Virginia Nursing Home Improvement Network and has extensive experience in dementia and long-term care. So again, welcome back with us, Sonia, and thanks for being here. And I will go ahead and turn the call over to you.
Thank you so much, Erica. I am so happy to be here today and look forward to this next hour of sharing some information that I have learned and practiced with multiple homes throughout the country, and I'm hoping that all of us in Virginia and Maryland will find this helpful and be able to think about how we can implement this in our own homes. So what we're going to do for the next hour is I'm going to talk a little bit about what dementia care consultation teams are, what they do, how they work, and why they're important. And really, this is a high-level overview of the idea of dementia care teams. It's a framework to get you moving forward, and I hope that it will give you the tools that you need to consider doing this. And if there's any other questions, as Erica had said, certainly we'll have a question and answer period at the end of the webinar, but also feel free to type in questions as they go along, because that also helps me to make sure that I'm being clear. And if you guys have any specific questions at that moment, I certainly welcome them. So before we dive into the actual care teams, I wanted to take a step back and talk a little bit about an overview of kind of how we got to dementia care teams. Like, why are we even talking about this? And some of this is information I talked about on the last webinar, but just wanted to quickly go through it to set the stage of why this is a process that might be helpful to you. So one of the things that we talked about before was the idea that this focus right now on reduction of antipsychotics is really more than antipsychotics. It's really about how do we improve care for people with dementia in nursing homes. And although the numbers have been primarily the focus, we really need to think about the idea of shifting the whole way that we do things for people with dementia. And as a side note to that, if many of you may have already looked at the proposed regs from CMS, and they are actually proposing to expand antipsychotics to psychotropics in general. So yeah, I think that's a message from CMS that they also are looking at this more than just reducing antipsychotics. It's really a much bigger picture. So we really have to look at it as, seeing everything in a different way. One of the challenges we've had with antipsychotics is that we see dementia primarily through this medical lens. And we see dementia primarily as a medical problem and the quote-unquote behaviors of people with dementia as medical problems. Naturally, we're going to seek out medical solutions. And is this because we're bad people? No, it's because this has been the best course of action that we've had, for responding to people with dementia. But we know now that there are other things that we can do to help people with dementia. We also know that antipsychotics really can be a Band-Aid because they really are not helping us to seek more deeply why people with dementia are acting where they are, what's happening with that person, in ways that we can really try to understand their needs better. And I would say that even non-pharmacological approaches can sometimes be used as a Band-Aid because if we're still just using them without really trying to understand what the person is going through, what the person with dementia is experiencing, there's still that danger that they're really not going to meet the needs of the person with dementia. And, a simple example I give is that if you have a resident with dementia who is upset because someone is asking her to take a shower and she doesn't want to take a shower and she's very agitated, aromatherapy is really not going to help her in that moment. It's really understanding why, having a shower is upsetting to her, what's going on with that situation. So we really have to move to person-centered care is the bottom line, and we really need to see, quote-unquote, behaviors differently as forms of communication and really trying to understand the person. So this is the value of moving to person-centered care. It gives us a much broader way of looking at how to care for people with dementia. So I believe that person-centered care is the prescription. I believe that this is fundamentally kind of where we have to go with not just people with dementia, but with all the people that we care for. And this gives us guidance, not just in terms of how we care for people with dementia, but as professionals of how do we respond to people with dementia, how do we see dementia. So it's a framework that we can use to better understand how to care for people with dementia. And fundamental to this is really understanding that we have to start with a person with dementia. We have to understand things from their experience. We have to try our best to understand why they are acting that way. Knowing each person. And you'll see why this is so important when we start to talk about care teams, is the opportunity to really understand and get to know each person and develop ways of approaching them and interacting with them that are individual to who they are. And so fundamental to this idea of dementia care teams also is rethinking about what behaviors are and reframing them as actions and reactions, that maybe behaviors are really the way people are acting. Why are people acting that way? And then hand in hand, this is one of the ways that we reframe behaviors, is trying to look at it differently, so that we can see really behavior as a form of communication. So in hand, and this is a framework that we're going to talk about with dementia care teams, is trying to understand the reasons behind actions and reactions. Trying to look at all these different things that could be happening with someone that might explain why they're acting that way. Why does Mrs. Jones not want to take a bath? Is she in pain? Is it the environment? Does she just not like the person that's giving her a bath? Trying to understand things a little bit more deeply. And then coming up with solutions, coming up with ways to respond to somebody. So this is the work, essentially, of dementia care teams. And so we recognize that with every person that we care for, it's really never a one-size-fits-all approach. It's really very individual, and that is fundamental to person-centered care. So this is the foundation from which we'll spring when we talk about dementia care teams. And this is the foundation that you also are probably going to need to share with your team as you're developing dementia care teams to help them understand in the context of why this is a different way to approach situations. And I say that because many times when I go around and talk to teams and nursing homes, there is a feeling among staff that the behaviors that they're seeing in people with dementia, that's just the way it is. That's what people with dementia do. And so I think there is a need to educate about that. That's not necessarily true, that what we are seeing as a form of communication, and it's something that actually we can either prevent or lessen or respond to in a different way. So let's jump into what are dementia care consultation teams. So I'll tell you that this term, dementia care consultation team, is something that I just kind of created to explain what this is. You can really call these teams whatever you would like. Sometimes people call them behavioral consultation teams. One home I'm working with calls it an exceptional review committee. It's really up to you, but they're fundamentally the same. So what are some key characteristics of these teams? Well, they are intentionally created, and they're in-house, and they're interdisciplinary. So why are those three components important? Well, they are organized in a formal way, so it isn't just an informal group of people getting together. It is a formal process in which these people are coming together to actively work on something. It is in-house, and it is very important that this team is made up of the members of your team. Someone like myself can come in as a consultant and guide you in these processes, but I don't know your residents. I don't know you. So I can only really provide coaching in the process. It's really your staff and your team members that know residents the best. So it really needs to be something that is made up of you. It's interdisciplinary, which we'll talk about more. And so basically the charge of this team is to better understand the actions and reactions of people with dementia, identify ways to respond, and really ultimately enhance well-being for people with dementia. So what are they? What are these teams? They're collaborative. So it's about creating a space for people to come together so that they can actively talk about residents. They can try to understand where residents are coming from. As we all know, sometimes these spaces have to be created because they don't happen naturally all the time in the busyness of a day. And sometimes they may just happen with a couple of people. But the idea of this team is to really get more input from different folks. These teams are empowering because they give people a voice, especially CNAs, who are closest to the residents and know them best. And these teams are really more than an antipsychotic review team or an antipsychotic review committee. You may have one of these committees already or something like this where you do review residents to see who could be reduced for antipsychotic usage, who could be taken off antipsychotics. I would say that this is a step further because this is really not just about the antipsychotics. This is really about trying to understand how in another way to address the behaviors of a person and to truly understand what's happening with them. This is also an opportunity for a QAPI project. As we can see, QAPI is definitely moving along and happening, and there's kind of two ways in which we can think of these teams as being a part of this. Is the actual development of the team itself, you could position as a performance improvement project. So the actual development of the team, that being your goal as an opportunity to kind of practice the collaborative team model. And so your goal could really be about creating this team itself. Or if your goal is just general reduction of antipsychotics or psychotropics or improving well-being of people with dementia, this could be a vehicle for accomplishing that goal. And so I definitely encourage you to think of it that way and to look at the worksheets for performance improvement projects, especially the charter, which can kind of help you guide through what this team can accomplish, that you can use it as a QAPI example. So what do these teams do? They have a couple of different functions, and this is very much up to where a community is, where they'd like to go. So if you already have teams that are doing this type of work, you may decide to do some of these other activities. I think fundamentally the idea of these teams are to discuss individual residents with dementia and to really try to individually look at them. However, there are many other opportunities for this team. I think it's a great place to look at trends and actions and reactions, to look at trends across the organization of when you are seeing behaviors, where you're seeing behaviors. I've worked with homes where we've looked at incident reports in these teams, and we've seen clear trends of when these behaviors are happening. Like there was one home I was working in where we saw that almost all of the incidents in their incident reports were happening in the shower room. And so we're able to kind of pinpoint that this is an area that we can work through as a team and to come up with ideas on how to better make the shower process for people with dementia in the hopes of preventing or lessening some of the negative actions that we were seeing. This is also an opportunity for the team to brainstorm ways to overall enhance well-being for people with dementia. So not even just about antipsychotics or behaviors, but how do we create better lives for people with dementia? What can we do? And to evaluate overall dementia care in your community. This is a great team that can take on all of these different activities. So how do they work? So let's talk about the team makeup first. What I suggest is that you have both a leader and a co-leader of this team. So that way, if one of the folks isn't able to make a meeting, that the other person is there. But you have two people sharing kind of the responsibility of moving this team forward. I think that the team members need to be from various departments and disciplines, and this is so extremely important. The team really can't just be department heads. It can't be just nursing. It really needs to be recreation, social services, housekeeping, perhaps dining, whoever you think is appropriate. But in terms of having representation from different perspectives is so key, because each of these folks is going to have a different piece of information that's going to be helpful to you. And I think we all know housekeeping, they know a lot of stuff about residents that sometimes in nursing may not be known. And so it's very important to have voices from different departments. And it's really important to have both supervisory and non-supervisory staff. And I would say of utmost important is that CNAs are included on this team. CNAs know the residents the best, and they have the best information that they can provide to the team about residents. So it must include CNAs. The way this has worked in practice I have seen is that sometimes some organizations have lead CNAs, for example, and they'll ask the lead CNAs to make shifts to be a part of this team. Some folks just have an informal leader in a CNA that they ask that person. And so what you might see is that as you look at specific residents, that you're going to need to invite other staff that are closest to that resident. So you might have these core groups of CNAs, but then there's other CNAs you may invite to specific meetings, or that you would be seeking out information from those specific CNAs to bring back to the meeting. So there is a core group, and I would say that it probably looks best if it's not too big, like 4 to 6 people. There's some teams that have been as small as 3, and some teams I've seen as large as 8 or 10 people. But I think 4 to 6 is probably a good number. I think as you're starting this team, it's important to have regular meetings, at least first, that people are committed to the process. They know that this is something that's going to happen. I think as soon as the meetings stop happening, people kind of gets off everyone's radar. So it's important to say, for example, maybe monthly, maybe even more than that, we're just going to meet this time at this space. And, in some cases, it does work to combine this with an existing meeting. So if you do have some other type of meeting where it makes sense to have this be a part of it, that's fine. But I would also say that, to ensure that there is enough time for folks to be able to really go through the activities of this meeting and reviewing individual residents. The other thing to consider if you are combining meetings, like with, for example, an antipsychotic review committee, is that there may need to be different people on both of these teams, so that it may be necessary to have a separate meeting because, again, you really want the staff that are closest to the residents in on this. A technique that you can use during meetings that is very helpful is the learning circle. In a learning circle, each person in the room has an opportunity to answer a question without interruption from others. And so this might be a good tool that you can use initially as you're starting the meeting so that every person has a voice. So, who is discussed? What happens at a meeting? Well, there's 2 different ways in which you can approach this. 2 different ways I've seen it approached is the team itself identifies residents to be discussed. And this might be the way that you start these teams. Is that in the beginning, you might look through your list of people on antipsychotics. You might look at your 24-hour report, notes, instant reports, information you get from team meetings. However you collect the information to identify those residents with which staff are having challenges related to their behaviors. So it doesn't necessarily have to be like catastrophic reaction types of behaviors. Just be that, Mrs. So-and-so keeps wanting to go outside and we're trying to find other ways, to distract her from needing to go outside all the time. Whatever these challenges are that are either stumping people or causing challenges with time or, causing challenges with other residents, but that might be something that your team just tries to identify is who is it that we are going to discuss during these meetings? What is the criteria? One of the questions that people have asked me is, should we allow residents that have psychiatric conditions to be reviewed in this committee? And I think that's entirely up to you. I think there's a lot of blurred lines at times when we're talking about antipsychotics in terms of having psychiatric symptoms and dementia. So it's really up to you to determine. But I would keep this dementia focused in terms of trying to understand the disease. And so that's something that you may also need to determine when you first meet. Another way to approach this is that the team asks for referral to this committee for residents to review. So sometimes one of the homes I'm working with in New Jersey has developed a process where they actually have boxes at each unit. And the staff put in a little slip of paper with the name of a resident and a situation that's happening, and that goes to the review committee, to the dementia care team, and then they look at this resident and try to understand what's happening. In that case, what was vitally important was that all of the staff in the community were in service on the process. So I would certainly suggest that whatever process you use that is clearly articulated to the rest of your staff, that they understand how they can refer people to this team, and to understand that this is not intended to be like a rapid response team in emergency situations, that this is really for understanding people and trying to dive deeper. So before your team meeting, what you want to do is to identify which residents that you're going to be discussing and to communicate this to the rest of your team. So if you have 5 residents that you're going to be talking about at the key meeting, to let people know that you're going to be talking about these 5 residents, including the staff that care primarily for those residents, so that if they need to be invited, you can invite them ahead of time, and to remind everyone at the meeting time at least. So this is a great function of the leader or co-leader. And I would say as you're developing all these team roles, to make it really clear to people what is expected, that as a co-leader, that you'll be charged with identifying which resident, communicating, whatever it is, but that everyone kind of really needs to know what their responsibilities are going to be. So at the meeting, as you're discussing individuals, the process that I like, that I have used before, that I find is a good framework, but certainly you can use whatever framework works for you, is the hand-in-hand brainstorming worksheet, which was included as a handout with this webinar. And the one that I attached is a slight modification from the one that's in the hand-in-hand training toolkit that has a little bit additional information that you can use during one of these meetings to go to a resident. So what I have found is that one of the most important things in these team meetings is to truly identify what it is that is the action of the resident that we are concerned about in a very specific way. Sometimes I have heard in meetings people say things like, this resident is agitated. Well, what is happening? When was this person agitated? When was a specific situation? And to really dive down about what we are talking about. Sometimes what I have seen is as we've begun talking about a specific action of a resident, we've actually determined that it's really not a problem. It's just something that has been concerning to people. And so we can talk about it in a different way. It's not necessarily something that we're going to stop, but is there something else that we can do for this person? And an example of that was a resident who was crying a lot. And we realized that we may not be able to stop her from crying because that's where she is in her dementia. However, what can we do to try and bring her joy in her day? So to really dive into when is this thing happening, it's really important to ask the team also to talk about when this action is not happening. And I think that's a question that sometimes gets lost because it feels like these things are happening all the time. But when we really look at them, it may be that at a particular time of day with a particular staff person, but actually it's not happening. And that's really important information to know when we're talking about identifying how to respond to a person. So going through all these questions on this brainstorming worksheet is really the work of the team. And looking at each person and really being open to understanding all the possible reasons of why a person may be acting this way. And when we go through this process and we try to understand whether it's something in that person's life story or past or situational or environmental, then we can come up with ways to respond. And then the team can do the work of really trying to come up with various ways that they can try to either lessen or prevent this action if necessary. And I think, to also be realistic about what this is going to take. And a quick example is there was a resident I was working with who she would yell out a lot, help. People walked by her, help, help, help. And it was becoming very irritating, frankly, for the other residents and for staff. And what we came up with in the team was that each staff person needed to commit to at least spending 3 seconds at looking her in the eye and saying, hi, Mary, how are you? And when every person was able to do that, we found that Mary had less of a need to reach out to us, which was her need for security and belonging. And this was a response that we identified that then really involved the entire staff. And so we had to communicate that to everyone, explain the reason why we were doing this, and really kind of get everyone bought into the process. So this last part of communicating the responses that the team comes up with the rest of the team is so vitally important, because in order for it to be successful, it really needs to be communicated to all the people that are going to be using this response. And so this is all part, of the teamwork. And I think at the meeting, it's really important to identify who is going to take responsibility for communicating this information with the rest of the staff, how, and to follow up and to see how that's going. So a couple of brainstorming rules. And this might be something you would share with the team, maybe your first meeting, to kind of talk about, what kind of the rules or the standards are. There really are no dumb ideas. Everyone in that team really should feel comfortable of being able to say whatever they were thinking without feeling like they're judged or criticized by others. And so I think it is up to the leaders and the facilitators of this team to really create a safe place where we're open to hearing all different ideas. And one of the things you may see in your meetings is, especially with CNAs, they may be very hesitant to participate at first. And so I think, actively spending the time to encourage them to share their ideas and to reinforce what they're saying positively is really important. And asking questions about what people are saying and allowing each person to ask questions of each other is extremely important. It's so important this is an open forum that people feel like that they can just say what they're thinking. I think it's also really important that the team has an attitude of we can't stop it, we did that already. This is a very common thing that happens in these teams, is that we have a resident and we're talking about the person and what might be going on with them. And another person may say, well, we've tried everything. We've done all that already. It's very difficult when you have someone in the team who has been caring for a resident, and they may be perceiving this process as being critical of their skills. So they might be thinking that as a CNA, I'm not able to do this well, and this is why all these people are having to sit here and review this resident, is because they're criticizing that I'm not doing my job. And this is coming from the CNAs have told me sometimes the way it feels. So I think it's really important that we're sensitive to that, and that this is not about anyone not doing things wrong, but this is about us as a team coming together to try and identify better ways. And that even if we did try something already and it didn't work, that there are likely different ways to do that. So if we have a resident who doesn't want to take a bath and you feel like that you've tried everything possible to encourage that person to take a bath and it doesn't feel like it's working, to try it again in a different way with a different person or at a different time of day until possibly you get it right, but that to really encourage the group not to stop at that. So at the meeting, what you also want to do on ongoing meetings is to follow up with previous meetings. So who tried the responses? Did they work? And so this also requires a little detective work and preparation for the meeting. So, it should be clear to the team members that at each meeting, they'll be responsible for trying to understand from the rest of their staff whether or not they tried responses that were identified in the team, how they worked, why they didn't work, and coming with maybe new ideas of what else could be tried. So I think that it is important to kind of talk with their team members about that, of the need to really reach out to their coworkers and talk to them about how they're using some of the responses, whether things are working, and to come back to the team meeting with that information. And so, if there needs to be a new plan for a resident, to go through the process again, and then to again communicate this new plan to the rest of the staff. So, if you are in a situation where you're feeling like that you don't really have that many residents with behaviors, and we think we're handling that pretty well, these are a couple of other things that you can use this team to do. And I have had this situation where people have felt like that they really weren't having that many problems with behaviors, and so they wanted to better understand how they could take this to another level. So one of the things that you can do is you can look at incident reports and 24-hour reports and other sources of information to try to get a sense of when are behaviors happening. Are there particular times of day? A great example of this is shift change. Likely many of you have noticed that at shift change there is an increase in behaviors of people with dementia. And if this is something that you are seeing across the board, this is a great exercise for this team, just to really brainstorm, what can we do differently about this? Are there different things that we can do around that time period to try to either prevent or lessen behaviors? Who would be involved in that? And to really think about this as a team. Are there, specific activities that we're seeing people with dementia having behaviors? Is it, as I said before, about bathing? Is it some type of personal care? Is it during meals? What are these patterns and trends that you are seeing? Another function is to take it even a step further and to talk about how is the team going to enhance well-being for people with dementia. So what you see up on the screen here are domains of well-being. These were developed by the Eden Alternative and Dr. Al Power, who wrote Dementia Beyond Drugs. And one of the things that Dr. Power talks about is the idea that when we're looking at improving care for people with dementia, maybe what we should be starting with is meeting these needs, in addition to really thinking about how we're stopping behaviors. Because we all know it's really more than that. It's really more than reducing antipsychotics. It's really more than just stopping behaviors. It's about how do we create better lives for people with dementia. So this might be a function of your care team, is that you are able to brainstorm how are we enhancing well-being for people. So some specific questions that you can use in your team meetings are, basically what are we doing in each of these areas to create well-being for people with dementia? How are we creating joy? How are we creating connection for people with dementia? Do you feel that we're doing good in that area? What else could we do? And so this is an opportunity for this team to take this concentrated amount of time and to use that time together to improve dementia care. So why are these teams important? Well, I think bottom line is that they do try to improve care for people with dementia, but there are many other benefits that I think are recognizable. This provides a time and a place for people to meet and discuss. So if you are committed to person-centered care, and if you are wanting to move forward in person-centered care in your community, one of the things that we really work with people to help understand is that structure leads to change. That in order for change to happen, there does need to be structure. And this is a great example of that, is that when you create these teams and these meetings in a sort of very concrete way, it is allowing a pathway for people to come together and to practice collaboration and teamwork and individualized care and person-centered care. And so in many ways, a dementia care team can even be like a door to person-centered care, because it's a small way of beginning to practice these ideas in a smaller group of people with dementia. So it also provides this framework. It's a framework to brainstorm actions or reactions, which as we know, it does not happen on the floor necessarily all the time because people are so busy. So often what we see is reactions to behaviors are reactive. They're very much about in the moment, what do we do to stop this behavior? And so this gives people an opportunity to take a step back and think about what can we do about this in the future? How can we change the way we respond to this situation? And this will help you reduce antipsychotic use because it will help you to better understand what that person's needs are. It does, as I said, support person-centered, individualized care because it is very much about focused on a person with dementia. One of the things that, again, has come up with the proposed CMS regulations is an increased focus on individuals and residents in care planning and them truly directing their care. And so naturally a question that has come up with this is, what about people with dementia? How do we create person-centered care plans for people with dementia when they may not be able to voice what they want? Well, I think what we all know is that people with dementia do voice what's important to them. They actually voice it many times through their behaviors. And so this is a way of really supporting individualized care and really trying to understand what people with dementia want. This is an opportunity to support staff. When one of the homes I'm working on, when we first started doing this, interestingly, the staff were perceiving it as, being critical, again, of their jobs. They thought that this meant that they weren't handling their residents, sufficiently. But when they realized that the culture that we were trying to promote is that we're all in this together, that your teammates are here to help you, and that maybe somebody else has the answer, it really changed the way that they were thinking. And staff were feeling better supported, so they weren't feeling like they were kind of left out there in the dust to handle difficult situations. But really there were people that were there to lend their knowledge and what they know about that resident. And so many times I've heard CNA say things like, well, I didn't know all the things about this resident. That person's social history is in the social services section of the chart. I didn't even know that, just like he was a teacher. I didn't know that she was a nurse. And so this is really an opportunity for everyone to come together. And I think ultimately we all agree that this is about enhancing well-being for people with dementia. And learning, it might actually make your job easier. A great example of this is one of the teams I'm working with. We had a situation where, in talking to the CNAs, we learned that in the night shift, there was a resident with dementia who they were having challenges with because they were saying that she kept wanting to go home in the middle of the night and that they were feeling that they had to provide one-on-one care for her for at least 3 hours a night to keep her from leaving the building. So we used this process to try to understand what was happening with this person. And as we started talking with the CNAs, the first thing that they were saying is, this happens all the time. It's always happening. It's always happening. So it felt like it was always happening. And they were so stressed out because this was 3 hours of one-on-one time a night, and they were kind of at wit's end. So as we started to talk about it, we realized it wasn't actually happening every night. It was happening occasionally. So what was happening around there? What are other things they noticed? As we went through the process, what we realized was that this individual's roommate would turn on her TV many times at night. And it was those nights that she was waking up. She was waking up, she had dementia, she was disoriented, and a natural thing to do was to say, well, I got to go home. I don't know where this place is. And so that's exactly what she would try to do. So the team was able to come up with responses to try to keep her from doing that. And it saved them 3 hours of time a night. So I think it's one great example of how this process can really help people. It's not just a nice to have. And it's really not just about the residents. It's about supporting staff and really trying to give them the support that they need. So what are some lessons learned? Some of the things that we've learned in implementing this is that it's so important to talk to all staff about this care team purpose, about the process and the benefit. And I mean all of the staff that would be in any way involved, because all of the CNAs need to know that this is a resource for them. All of the staff need to know the opportunity to refer residents to this group. It's extremely important that it is communicated throughout the organization. It's very important to formalize the referral process, that to this group. So if you develop a system where people can refer residents to this team, it's important to formalize that and not just to say this is the process. And so what I mean by that is creating a worksheet or creating a box or having a checkoff box in the medical record or whatever works best for you, or through the huddles of making sure that there's a way to communicate that information to the team. But if the process is not formalized, what I have found is people don't use it. And so to really take the time to communicate what that process is and what to expect from it. So if I'm a CMA and I have a resident, I refer that resident to the team. When is that resident going to be reviewed? How long do I have to wait to get an answer? Can I come to the meeting? So I think it is, it's really important to create that structure at the onset. And it might be something that you change as time goes on and as your needs change. An example of that is the home I was telling you about where they had the boxes on the units. What they would like to do is actually have almost like a hotline at some point where people can call and just leave a message about a resident. But the concern has been is that people are going to use it as an emergency type of situation, and they don't want that to happen. So you kind of will see and feel out what works for you as an organization. I think it's really important to clarify that this team does not mean that people are not doing their job. It really is about supporting people to better do their jobs, and that we all have these situations where we've tried everything and it seems like nothing's going to work, but there's usually someone in the organization that has some answer that's going to be helpful to us. As things come up in this team, what you also may find is that there's opportunities then to provide education on ongoing issues. So what you might see is that, for example, if there's a trend with residents becoming very upset during mealtime, now that's an opportunity to kind of say, what is happening during mealtimes? Is there a need for better education of how to support someone with dementia when eating? And so I think it's a really useful tool also to really look at those areas and opportunities for education. Ask for input on how this is working. Ask the team for input. Ask the rest of the staff for input. Is this working? Is it not working? If people are feeling like this is an exercise in futility, I think that's something to really explore. Is it because it isn't really doing what you hoped it would do? Is it because it's a process situation? Maybe meetings aren't happening. Maybe people are attending the meetings and they're feeling like they're not being heard. But this is where there is a leadership role in making sure that the team is continuing to happen. So if you're an administrator, if you're a DON, maybe you're not at these meetings, but still to really have a connection with them so that you are aware of what's happening and that you're constantly asking how you can support this team moving forward. And I think overall, this is a process that is really transferable to individualized care for all people, not just people with dementia. When staff are becoming familiar with this collaborative process where they're coming together, I think that this is a skill that you're going to see is so useful in many situations. And you might even find that people want to have meetings about other topics, and they'll be willing to be more involved in some of those. And not that I'm an advocate for more meetings, certainly, but that, creating the space for people, even if it is a quick huddle, I think it really helps for staff to have a voice. So we have some additional resources that perhaps you'll find helpful. The Advancing Excellence website has a lot of the resources from the National Partnership to Improve Dementia Care from CMS, and there is a wealth of things on that website. It can be very overwhelming. I will say that there are a couple of really good tools to help identify kind of where you are in this process of interdisciplinary care teams and some self-assessment tools, as well as some ideas about dementia care programs, about models of care. Has a really amazing amount of resources there, so I definitely encourage you to take a look at it. The Hands-in-Hand Training Toolkit is available online. You can download it for free from this website. You also can order it if you don't want to download it. So I certainly encourage you to use that as a resource for education or even just for quick in-services with your staff and trying to help them think through this process. And Module 4 is the module that focuses on brainstorming actions and reactions. So that could be a good precursor to this care team. The third thing is the VHQC Antipsychotic Medication Process Assessment Tool, which is a tool that we've developed to kind of help you kind of think through, like, where am I in this process? when I'm looking broadly at antipsychotic reduction, there are always multiple moving parts in how this can be successful, not just the actual review of medications, but the culture of the care, individualizing care, understanding how to how to know a person with dementia, how to know their life history. And so where are you in this area? And this tool might be helpful in identifying where your team wants to focus on. And lastly, as I had said before, the brainstorming worksheet, which is also included, I think is a great resource to use in the care team. So that's all I have to share with you today. I wanted to leave enough time for you to chime in and ask questions, so please feel free.
Thank you so much, Sonia. We have a few minutes for questions. So I'll ask Jennifer, our WebEx host, if she can go ahead and post the evaluation questions, and then have Erin, thank you so much for sharing with us how to ask the question.
Certainly, the floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7 to ask a question.
Sonia, while we're waiting for questions, I just thought I would ask if you could clarify something. Can you talk about how dementia care teams are different from, say, like a QAA team that's already in existence, and how that whether adding the dementia care team to that meeting may or may not be helpful?
Sure. That's a great question. I think the answer is somewhat dependent on how you structure your QAA teams and how, I guess, who's involved and all those different things. But I'll tell you what I've sort of seen is that what I've seen sometimes is the reason why these dementia care teams are different is because, one, they are wholly focused on dementia. So unless you already have that as a focus, this is a specific focus on dementia. Not even just people in a dementia unit, but people with dementia that live throughout your nursing home. The other thing is that, something I have seen is that in other QAA meetings, sometimes CNAs are not involved, or they're sort of tangentially involved. This is really an opportunity to get CNAs very engaged. So I think that, again, the factors of being all types of staff is vitally important and makes this unique. It is very much a working committee. It really is about brainstorming very specific situations. So that may or may not be what you do in your own existing committees. So I think it's a very focused thing. It may be something that you can add on to your existing committee. So I can see it working if sort of those conditions are met in the sense that it does include all types of staff, that you do have either a focus on dementia or there's a possibility of taking a time of that meeting to focus specifically on dementia, which may very well be possible. And I'm all for if there are any ways that you can collapse this into existing activities, make this as easy as possible, I'm certainly all for that. I think as long as this is not a check-the-box type of activity, that it's really something that's meaningful to you. And also, it might not be for everybody. This is something that, is helpful to some people, but some people may not find this helpful. And that might be something to kind of gauge as you go through the process.
Thank you. And let me check to see if any questions came in for Sonia.
There are no questions in the queue at this time, but again, if you do have a question, please press the number 7.
Sonia, with this work with dementia care teams, have you seen people try to measure or to gauge their success? I know, of course, there's always the antipsychotic quality measure, but have you seen people try to utilize any type of measure of success for this type of work or to develop with these types of dementia care teams?
Yeah, that's a great question. I've been on a couple of different levels. I've seen people just in and of itself of the existence of these committees. So if your goal is to have a dementia care team meeting, once a month, and we want X amount of people present, and, those types of, outcomes. Some folks are just using those as measures of success because they're saying, we are meeting 95% of the time, at most of the meetings we have 75% of people that are supposed to be there, that kind of stuff. So I think that's a helpful tool in moving along and starting this process, is setting goals that, you'd like, 75% attendance at each of the meetings. And so sometimes that is, and to reward people then, that if we actually meet our goals, that there's some sort of reward for that. So I think on one hand, that's one measure of being, in terms of other types of outcomes, what we've talked about in some of the teams is using just other types of tools of measuring person-centered dementia care. So some of these might be things like observational tools, where you are observing what people with dementia are doing in a given period of time and whether there's any difference in terms of interactions between staff and residents in a given amount of time. So this is this takes some time, certainly, if you are going to go into this process, but it can be helpful for people to kind of see, is the work of this team impacting the way staff are interacting with residents? And there are a couple of tools out there. There's a tool by Lynn Snow. It's called the ROAR, R-O-R, and I can see if I can get it shared with VHQC because I think it is publicly available. But what the tool does is it helps you measure time periods of staff and resident interactions to determine whether or not basically they are person-centered, what those interactions are all about. And so that might be one measure, for example, that you decide to use. I think it's a really great idea to think outside the box rather than just looking at antipsychotic usage of how else this team might be impacting. And another measure I can think of is just like staff feeling of stress or self-efficacy about working with people with dementia. So you might even just develop a couple of questions that you ask staff periodically, like, are you feeling better about helping, people with dementia? So I think it's a really good opportunity to kind of think about that, like what are your goals from this committee, and then how are you going to measure whether you're meeting them? And I'm happy to entertain questions about that too, and to talk about specific tools I've come across.
Absolutely. We were just talking here, I can imagine a satisfaction data in terms of even from not only from staff but even from family members might be something that might be helpful to gauge.
I think so. And that's a great point. I'm glad you said that, Erica, because it's not traditional to have, I haven't heard of a lot of organizations include families in these teams, but I can't see why not. I think it's a great opportunity to include family members, especially if that particular resident is being discussed, because obviously the family has tons of information about who that person is. So just to throw that out there as a consideration.
Wonderful, thank you. Let me double check with Erin. Erin, do we have any questions in the queue?
There are no questions at this time. Again, if you do have a question, please press 7.
Okay, well, I have a little bit, about 5 minutes to the top of the hour. Again, if anyone has questions, you can certainly put it through chat or ask us through the audio line by dialing 7, as Erin has mentioned. But Sonia, do you have any questions for our participants in particular, or anything else you would like to share with our participants today?
I would just ask that if any of you are either doing these teams or you intend to, that I would love to hear from you and just to hear about your experiences. I learned so much from you about how this is working in practice and how each home is attempting this differently, that it's helpful for me. And if you want to contact me, I'll also try and keep you in the loop and any other additional information that I gather on the topic. I know one thing just to keep in the back of your head is, from this project in New Jersey that I've been working on, we are developing a toolkit for, the project is called More Than Meds, and it's about implementing person-centered practices with the outcome of reducing antipsychotics, but also other things, obviously. And we're developing a toolkit that is going to be available freely to anyone as a result of this project. So when that toolkit is out, which will probably be sometime next year, just keep an eye out for it. I'm not sure who is going to be distributing at this point. but that it's something that might have some of this information and additional best practices in it. So.
Well, thank you so much for sharing that. We all look forward to seeing that next year and excited for the work that's being done. So thank you so much, Sonia. If there are no more questions in the queue, Erin, I guess I should check. Are there any other questions?
There are no questions at this time.
Okay, thank you. Well, then, thank you so much, Sonia. We appreciate your work and you sharing with us about dementia care teams. And again, if anyone has any specific questions for Sonia, we're happy to provide her information or to give questions to her. I believe that second slide in our slides that included her contact information. So feel free to contact her. She's a great resource and has a wealth of information. So if we can go to the next slide for us, we will just kind of close out today's webinar by just sharing that we have a save the date. The next Nursing Home Improvement webinar is on Wednesday, September 16th at noon. We will be discussing Team Steps, which is an evidence-based teamwork system to help improve communication and teamwork skills in your facility among healthcare professionals. So we look forward to you joining us for that, and please look out for some email information and reminders regarding that call. And with that, we just thank you for completing the evaluation that was pulled up right before the Q&A. And we will bid a farewell to you this morning, or actually this afternoon at this point, and thank you for joining us. Have a great afternoon, everyone, and thank you again, Sonia.
You're welcome. Thank you.
This concludes today's teleconference. You may now disconnect.